Okay, I got it.
You got it? Okay.
So just opening up with first of all, thank you very much for allowing me to share with you what we do. Um, the company, as you presented, is a next generation sequencing company, and this technology in the field of medicine is contributing to medicine in three different fields. One is hereditary diseases, pretty well established cancer, pathology, molecular pathology, our field of interest, and infectious disease. And it was serendipitous that our technology partner, BGI, was actually using the next generation sequencing to identify the new virus as the cause of the new SARS cases in Wuhan. And just to start from a few conceptual ideas, the main emphasis of AID genomics in corona is to detect the disease as fast as possible and to build a whole streamline around it, which has a lot to do with the reporting and response speed. And this is generally in the purpose of slowing down the transmission of the virus. Interestingly, the mathematics of the spread of a pandemic disease is very similar to a chain reaction in a nuclear plant. And this is pretty much the process of slowing down the reaction so that the capacity of the healthcare system is not overwhelmed. Okay, and the second term I wanted to share with you was that of the waves. So this is the Spanish flu. And if we look carefully at the dates of this disease, then the world has experienced this first phase of the coronavirus. And if it is coming back to us in the next winter in the Northern Hemisphere, that's where much of the casualties are expected. Although what you see later on is that by learning how to address this, the case fatalities are expected to generally reduce. So just to categorize the means of detection of the virus, generally speaking, most common is the real-time PCR. That's usually the kit to detect a viral agent. Because of speed and robustness, there is also a lot of kits which are based on isothermal amplification. The isothermal amplification is not so quantitative because it lacks the cycles of a PCR. And then there is a way to identify the virus either through antibodies, which are reagents made by the company, or by responding or by measuring the response to the virus in the immune system of the host. And to clarify, that last test is not actually informative in terms of the contamination or infectious potential of the individual. And so we've been focusing mostly on viral antigen as well as viral RNA PCR. Just to demonstrate the utility or the importance of this, you can see the comparison between South Korea and the United Kingdom, and you can see that South Korea had spent a lot of effort to detect the corona as fast as possible, and the consequence is demonstrated in the fatalities, where detection was not invested comparably. The cases of death are accumulating significantly. And this is exactly what happened in Wuhan. What you see here is the exponential growth of suspected cases, and quickly overwhelmed the infrastructure of the Wuhan laboratories, at which point of time BGI had set up an industrial testing facility, 10,000 tests per day. We've done a similar thing in Israel 2 times already, and intending to do it the 3rd time. And the point is that by introducing tens of thousands of tests a day, the company was capable of recognizing many more cases. The blue was what they could recognize in the previous technology. Red is what they found with the updated technology. And in gray, what you can see is the amount of cases that they avoided by blocking by quarantining, putting those new individuals detected as carriers in quarantine. And most of these cases would have accumulated above the threshold of the intensive care unit, which means higher chances of death. Another point in these tests is that RNA-dependent RNA polymerase viruses like SARS are incredibly variable, and most kits don't actually address the variation in sequence between one virus and the other. But really the purpose of all of this is in order to avoid transmission of the virus to a new case. So what I want to talk to you about is when does this happen and how much do we need to see of a virus in order to think that this is a dangerous situation. So what you can see here is that most of the infection cases or transmission cases occur within 3 days before the symptoms occur. And if we track those individuals daily, what we can find is that there are individuals which test very low, but within a couple of days become incredibly infectious, whereas there are individuals which are incredibly infectious at time of test, but if you follow them very quickly, the amount of virus decays. In general, the immense fluctuation that you can see here is drawing the attention to a point that I wanted to share with you, and that is we don't know how much virus we need to see in order to avoid an infection event. But if we are trying to extrapolate from the testing point to a couple of days later, it is virtually impossible to distinguish the low copy numbers and the high copy numbers. And really you need to test people before the events of multi-participant the multi-participant events, and this way by projecting very short time, you can be more accurate as per whether this person is infectious or not. So that's what we've been developing is a fast and point of care test, which operates within approximately, right now it's an hour and 45 minutes for 96 samples. And the last point I want to finish with is that from taking on a new case for testing through to a reporting of a result, everything is negotiated through the cloud and through an app on the phone of the person, so that every team that needs to be informed about the newly found case, whether it's epidemiological investigation team, hospitals, municipalities, etc., all get informed in real time at the moment that the PCR machine has finished the actual reaction. There's immediate reporting to all the individual teams that need to be informed. So from this moment, I will take questions, and sorry if I took a little long.
I think it was an excellent presentation, and in fact, even the way you explained how screening is now becoming more important over the years. I don't see a likely question, but over the chat box, there's not a question here. But how do you perceive now, when you talked about the second wave coming in? Do such screenings also help to be better prepared for the second wave? And will this now be able to really circumvent another pandemic?
So generally what we find is that the actual cases of infection are with an incredible amount of virus, especially the real important incidents that happened in many different places in the world involved people carrying hundreds of millions of copies of virus in their nasal fluid, as opposed to 100 copies, which is the limit of detection. And a lot of effort is going through to detect people with 100 copies, but they're clearly not infectious. In 3 days from now, they might be, but right now they are not infectious. So the concept is to develop a cheaper, faster, and less sensitive test so that you can repeat it every 3 days or so on key personnel, whether it's old age care, hospitals, transportation, strategic points, which are in hubs of multiple people flux. These are the people who need to be tested approximately every 3 days, maybe within a week, on a regular basis, and with a tool that is purposely not as sensitive. So this is what we are developing, and also the first swan of that technology is an Abbott antigen test that has been FDA approved just last week. This is generally the idea of going down with the price of the testing and the speed of the testing and reporting, and having that more systematically screen the population in ongoing time. This is what we need to still learn how to do. Basically everywhere in the world, it's not being done the best in an optimal way.
Absolutely, absolutely. And from an Indian perspective, I could really say that with the kind of population we have, we've already had enough tests which are going on, but I think affordable and accessible tests would be now really the need, which will be able to also curtail the pandemic.
Also, India is vast, and
yes,
in many places where we serve our products, when you have a big country, it's better to disseminate many little labs in different locations, because the transportation of the sample becomes a serious delay in the reporting.
Yes. This is something which is, seriously being thought in India also. Under we have our Prime Minister's program called the Ayushman Bharat Mission, and under that, the health and wellness centers are now going to be added on to extended, PHCs and CHCs, where this will be done, reaching the last mile connectivity. So, thank you very much, Professor Haviv.
There is a question on
great
the
talk.
chat. Dr. Raju, there is a question on the chat, if you can just address it.
Oh, okay, so there's a question by Chandan Banik, and it's to Professor Haviv. What would be the cost per test to end customers, and what is the time required to do the test? What is the sensitivity and specificity of the test? Now, this is pretty important because these days, with the plethora of testing devices out, it's a common man's question now.
Sure. Okay, so time to test, it's about half an hour for RNA extraction. And if it's a single sample, then we finish the real-time PCR reaction within 20 minutes, 25 minutes. And if it's 96 samples, let's say an airplane in an airport, then it's 45 minutes for the real-time PCR. So overall, an hour and 15. Prices, not with me, I'm sorry, but you can address the company for prices later. And sensitivity and specificity. So because our oligos are degenerate, we are capable of picking up specific vendors' cases. About 5% of the time in Israeli laboratories, 2 different commercial kits disagree with each other. One says it's positive and the other says it's not. And usually that happens because the probe sets of one company or the other do not recognize the variant this patient carries. So our kits will recognize both. So the specificity is going to be significantly improved. The sensitivity is slightly reduced, especially because of the speed of the test. So it's about 100 copies per ml. because it is a very fast test, we do not test at maximum sensitivity. I am arguing that this is not, it's actually a benefit, not a disadvantage.